Hey, it's Dr. Bill with just the tip of urology school. And today, let's talk about catheter problems. You're going to get called on for consultation or emergency call. And what you'll hear about is someone who has had either difficulty placing a catheter or problems with the drainage, or even worse yet, having a catheter that they have to remove and they just can't get it out. So let's tackle those things. Remember, as a physician assistant, a nurse practitioner in our urology program, you are much smarter than the average Foley catheter. So let's figure it out. So we can't place a catheter. We get this call a lot. People have tried and have failed. Oftentimes, you have to make a decision whether the previous catheterization attempts have been so traumatic that you might be better off placing a suprapubic tube. That is always an option. And if you're really in trouble and can't get there in time, or patient is complaining with significant abdominal distension, you can always ask for interventional radiology's assistance, and even at bedside, you can use a spinal needle and direct a emergency room physician how to just temporarily drain the bladder suprapubically. Oftentimes, the people who've tried to use a catheter are a little bit shy, and they may not be placing the catheter with the appropriate amount of force. Most of the time, certainly, they're just not using a lot of lubrication. Most of the Foley catheter kits now come with a little crazy packet of lubrication jelly, which is simply not enough. So you can direct the nurse, or you can go to the hospital yourself and place about 10-15 cc's of lubricant in a syringe without the needle, and gently place it in the meatus, whether it's a male or female, and that certainly will help with lubrication, help with comfort, and done appropriately will distend the bladder. People who have problems putting a catheter in will automatically go from a standard 16 French to a 14 French or a 12. Try going up to 18 or 20. You have a larger caliber, a stiffer catheter, and sometimes with the appropriate amount of tension, you can get through the obstructive point. When you're in the urethra and bypass the meatus, make sure you're not dealing with meatal stenosis, but you bypass that. Now you're in the urethra, and you feel you're almost in, but you feel some obstruction. Commonly, that is the external sphincter. You have them cough. Their response is for the sphincter to tighten up. Keep the tension on the Foley, and after the sphincter tightens up, it will reflexively, is that a word? Yeah. Relax, and the catheter should slip in. To make sure that your catheter is in the correct position, slowly inflate the balloon. Now, if you're having a lot of tension with trying to inflate the balloon, or the patient is complaining of a lot of discomfort, you may be in the wrong place. Certainly in men with large prostates, you may have stopped at the prostatic urethra. So you have to continue with your game plan and moving forward. Placing the male urethra or the pendulous urethra on stretch also gives you an opportunity to bypass the urethral folds. Sometimes bedside urethral dilatation is required. You want to make sure that you're appropriately trained and comfortable with those procedures if necessary. And again, as mentioned before, if you decide that the patient has gone through enough aggravation and you're not equipped to offer endoscopy at bedside to visualize what's going on, a suprapubic tube at bedside, performed by you after the appropriate amount of training, or interventional radiology is appropriate. Sometimes you get a call, the catheter is in, it was draining, it's no longer draining. Well, the first thing you want to ask is, have the patient had any recent surgery or hematuria, history of stone disease, anything that predated the call you got or the complaint of poor output? It may be the patient is not draining or making urine, so you have to you have to make sure that you have a good feel for the fluid and electrolyte balance of the patient. Sometimes the patient is doing great, the catheter is in, but there's nothing in the urinary bag and it's leaking all over around the Foley catheter. That's usually a spasm issue. Sometimes the catheter is displaced. You can determine that through gentle irrigation, if it drains nicely after placing some irrigant in the bladder. If there's evidence of significant contractions or irritability of the bladder, the patient is likely spasming and the pressure is just placing urine around the Foley catheter, not emptying the bag. That can actually also occur if the drainage tubing has been kinked or obstructed. Sometimes patients sleep overnight with a kinked catheter, or it's inappropriately secured to the leg, so you want to ask about that. If there is evidence of bleeding or evidence of sandy-like material, stone debris, or any type of mucus debris that's clogging the catheter, then you need to irrigate. Most people do not put enough irrigation in. You get a large 50, 60 cc irrigating syringe and gently put a couple of those syringes in, about 100, 120 cc's of fluid. Remember, the bladder capacity of most bladders is 350, 400, 450. So if you're only putting in, if the suprapubic area is flat and there's not a lot of urine there, and you only put in 30, 40, 50 cc's, you may not be expanding the bladder enough, and all that means is that the bladder mucosa is obstructing the drainage ports of the Foley, and you're never going to get anything in or out. So keep in mind, gently place about 100, 150 cc's of irrigant in the bladder before you begin to aspirate, or even before you begin to let the catheter drain. And remember, that's a good tool. Sometimes we're too vigorous in aspirating our irrigant from the bladder, and we just suck the bladder mucosa up through the tip of the Foley and nothing gets done. So placing the irrigant, releasing the syringe, removing the syringe from the Foley, and letting the Foley passively drain is another good way of determining, one, if your catheter is patent, and if the patient is making urine. Another trick, and don't hesitate to get another person at bedside to help you, is if you deflate the balloon, lubricate the meatus, and then place the Foley catheter all the way into the bifurcation of the drainage and the irrigation port, as well as the balloon installation port, you're essentially sweeping the floor of the bladder. And so what you can do as you place the irrigant you have in the bladder, 150 cc's or so, have your partner gently aspirate as you're sweeping the floor of the bladder, going in and out, and that picks up a lot of debris. It picks up a lot of clots that may be on the floor of the bladder. Remember, you may have clot retention, but in a continuous bladder irrigation system or a three-way catheter, clear irrigant is going in, clear irrigant is coming out, but the bladder is still distended. So what might be occurring is you have a lot of clot at the floor, and the ingoing and outgoing fluid is just sweeping in and out without being blood tinged or adequately irrigating or draining the Foley out. So sweeping the bladder of debris or of clot is actually a good little trick to utilize. And then finally, sometimes you get that call, I've tried and tried and I've tugged and tugged and I can't get the catheter out. And so there are several things to think about. One is that the drainage port or the drainage port where the continuous bladder irrigation is going in, or the Foley itself has been clogged. So what you can do in a three-way system, you can take a small wire or a guide wire on the larger ports and just run each channel through with the appropriately sized equipment. On the valve where you're inflating the Foley, you can cut that valve. Sometimes that will allow for appropriate drainage if there's a faulty valve, or if that area is stuck as well, you can take a very thin wire that's in most urology emergency kits, and you can run that wire through the small channel, and you can pop the balloon or clear the channel itself. Mineral oil has been utilized in the past to hyperinflate and allow that balloon to dissolve if the balloon is not deflating appropriately. When you do that, make sure anytime you impact change of that Foley balloon by bursting the wall, make sure that when you ultimately remove the Foley, you're inspecting the walls of that to make sure that you don't leave any pieces of foreign body behind. Not terrible if it is at some point an elective cystoscopy to irrigate the bladder of the foreign body is appropriate. In women and in women who you can't bring that you can't drain the balloon or deflate the balloon using a transvaginal approach by sticking a very small needle guided by your finger. You can palpate an inflated balloon on thin men and women. You can go suprapubically as well. You can often just ride the symphysis pubis on down and tugging in on that balloon, and that will often successfully deflate. The last real quick note with Foley catheter problems is how we manage hematuria. Oftentimes you have to make a decision, though the hematuria can come from anywhere, but it can certainly come from Foley trauma. It can come from a large vascular prostate. So overinflating the balloon once an appropriate catheter is placed in the patient who you believe that the bleeding is coming from a prostate issue, overinflate the balloon. You can a 10 cc balloon, you can go up to 30 cc's comfortably. A large 30 cc balloon, I've often placed 90 to 100 cc's comfortably. And what that does is expand the balloon. You put a little traction on the Foley, and what that balloon is doing is putting external pressure or compression on the capsule and helping tamponade, if you will, any areas of bleeding. Also, you want to make sure that if there is significant bleeding, what the coagulation status is of the patient, and if the patient is on any anticoagulation, can that be temporarily stopped. Another trick I like to use in the appropriate patient, as long as we're not talking about an urgent situation, when we have time for finasteride or medication to take effect, to not only does finasteride do what? It shrinks prostate tissue, it shrinks the blood vessels and can often within several days help us manage hematuria that's secondary from a juicy prostate. So these are all little tricks of the trade. Look at this as a guideline on what you can and what you shouldn't do. And again, look at the AUA updates. There are some great guidelines on the core curriculum itself. So once again, Dr. Bill with just the tip of urology school talking about Foley catheter issues.